The money trail. Who profits when algorithms ration care? Let's follow the money. When algorithms decide who gets care, financial incentives are often hidden in the code. Insurers may save millions by denying or delaying treatments, while patients face real health consequences. Who really benefits when care is rationed by an algorithm? Mini Leadership Lab. Imagine you're a policymaker. An algorithm saves the hospital $10 million but excludes undocumented patients. What's your call? This scenario challenges us to think about the values embedded in our systems. Is it acceptable to prioritize cost savings over inclusivity? What are the ethical implications of excluding vulnerable populations? As a leader, how would you balance financial pressures with the need for equity and justice? Your decision shapes not just policy, but the lives of real people. Insurers and hospitals often tout efficiency and cost savings. But what happens to patient outcomes? Studies show that when cost-cutting is prioritized, patients may wait longer, receive less care, or be denied vital treatments. The savings for insurers can mean real losses for patients. Systems leadership means asking, who is really setting policy? When we follow the money, we see that those who profit most often have the loudest voice in shaping the rules. True leadership demands transparency, so we can see not just who benefits, but who is left behind. The transparency gap. Algorithms are often treated as black boxes, their decisions hidden behind layers of code and secrecy. Would you accept a life or death decision from a doctor who refused to explain their reasoning? Yet that's what happens when we trust algorithms without demanding transparency. If we wouldn't accept it from a human, why do we accept it from a machine? True transparency means not just knowing that an algorithm made a decision, but understanding how and why it reached that conclusion. It means being able to question, audit, and improve the system to ensure fairness and accountability. To build a fairer system, we must follow the money and demand accountability. Only then can we ensure that algorithms serve people, not just profits. Welcome to Tomorrow's Consciousness with your host, Rukia, where we explore the future of leadership, equity, and public health. Disclaimer: the following content is for educational and informational purposes only. It does not constitute medical, legal, or financial advice. Please consult a qualified professional for guidance specific to your situation. Today, we'll uncover who sets policy when AI begins rationing care, and what that means for leadership, equity, and the future of public health. Future scenario simulation. Imagine it's 2035. In this world, artificial intelligence decides who receives organ transplants, cancer treatments, and even mental health referrals. The system is efficient, but who oversees these life and death decisions? Is it doctors, policymakers, or the AI itself? Now, picture yourself or a loved one living in this system. How would it feel to trust your future to an algorithm? Would you feel safe or anxious? Who would you want making these choices, and what safeguards would you demand? In this future, transparency and accountability are more important than ever. We must ask, who is responsible when the algorithm gets it wrong? How do we ensure that human values and ethics are built into every decision? If an algorithm decides who gets care first, is that medicine or policy by another name? This isn't a hypothetical question from a science fiction novel. It's a reality unfolding in emergency rooms, insurance offices, and hospital boardrooms across the country. We're standing at a profound intersection of technology and humanity, where the lines of code that promise to save us could also deepen the divides that already exist. The promise is immense: a world where diseases are caught earlier, treatments are personalized, and healthcare is more efficient and accessible for everyone. But lurking within that promise is a risk that we might accidentally build our biases, our blind spots, and our societal inequities into the very systems designed to heal us. Let's talk about the new gatekeepers in healthcare: algorithms. These complex mathematical models are the invisible engines of modern life, and they've moved from recommending movies to making life or death calculations. They are not just neutral tools. They are products of human choices about what data to use, what outcomes to prioritize, and what values to embed. And they are everywhere. Those invisible decision makers behind your insurance app, which might use a model to review your claim for post-acute care. These systems can process tens of thousands of cases in minutes flagging them for denial if a patient's recovery doesn't match the algorithm's predicted timeline. A human reviewer might spend less than a minute on the algorithm's decision before finalizing it. The goal is efficiency, but the result can feel like a cold, automated rejection when you're at your most vulnerable. They're in your hospital's check-in kiosk, which does more than just take your name. It instantly pulls your electronic health record, cross-references your insurance information, and runs a preliminary acuity score based on the symptoms you enter. This score can determine not just your place in the queue, but which ward you might be routed to, or even what level of preliminary testing is automatically ordered. It's a silent, instantaneous sorting mechanism. And they're in the chatbot that triages your symptoms at 2 a.m. That friendly conversational interface is the front for a rigid decision tree. It asks you questions, matching your answers to a pre-programmed library of conditions. If you say chest pain, it might tell you to go to the ER. But what if your symptoms are atypical? What if a woman's heart attack presents as jaw pain and nausea? Can the chatbot understand that nuance? And who is responsible if it gets it wrong? These aren't just lines of code. They're shaping who gets help, how fast, and sometimes who waits. Picture this. A 45-year-old woman, let's call her Sarah, walks into an emergency department. She's feeling a crushing fatigue, shortness of breath, and her heart is pounding. She enters her symptoms into the check-in kiosk. Before a triage nurse even lays eyes on her, an algorithm gets to work. It pulls her vitals from a wireless cuff. Heart rate 130, blood pressure slightly elevated. It scans her entire electronic health record in a fraction of a second. The algorithm sees a note from 2 years ago, a diagnosis for an anxiety disorder. It correlates the high heart rate and shortness of breath with the historical data. The pattern matches panic attack with a 92% probability. It decides instantly. Sarah is flagged as low priority. She's sent to the main waiting room with an estimated wait of 3 hours. But then, a veteran triage nurse, taking a brief moment between patients, glances at the waiting room. The algorithm saw data points. The nurse sees a human being. She notices the subtle gray pallor of Sarah's skin, the slight sheen of sweat on her brow, the way she's unconsciously clutching her left arm. These are physical cues, whispers of distress the algorithm wasn't trained to recognize. It's the human touch, the intuition born from decades of experience. Trusting her gut, the nurse bypasses the algorithm's cue and brings Sarah back immediately. An EKG confirms it. Sarah is having a heart attack. The algorithm was logical, but wrong. The human nurse saw the truth. In this case, the system worked because a person intervened. But what happens when we trust the machine too much? What happens when that nurse is too busy to look up? The patients appeal. When an AI denies care, some patients fight back. The appeals process is complex, slow, and often stacked against those without resources. Studies show only a fraction of appeals succeed. Who has the privilege to challenge the system, and who is left behind? For many, the process is daunting. Forms to fill, evidence to gather, and long waits for a decision. Those with legal knowledge or support may have a better chance, but most patients give up. This dramatizes the inequity built into the system, where the ability to fight back is itself a privilege. Now, zoom out from Sarah's story. Across the country, hospitals and health systems are using AI on a massive scale, sifting through mountains of data to manage the health of entire populations. They're predicting outbreaks, flagging high-risk patients for proactive intervention, and even suggesting treatments and drug dosages directly to physicians. It sounds like science fiction, but it's happening right now in the background of every visit. But here's the critical flaw. These algorithms learn from the world as it is, not as it should be. A landmark 2019 study published in Science exposed a shocking example. A widely used algorithm designed to identify high-risk patients needing extra care was found to be dramatically biased against Black patients. Why? The algorithm used past healthcare costs as a proxy for future healthcare needs. It assumed that people who cost the system more were sicker. But because of systemic inequities, Black patients, on average, incurred lower healthcare costs than white patients with the same number of chronic conditions, due to factors like lack of access, mistrust in the system, and implicit bias from providers. The algorithm didn't see sickness, it saw spending. And so, it incorrectly concluded that Black patients were healthier than equally sick white patients, locking them out of programs designed to help the most vulnerable. The data was skewed, and so the decisions were too. This brings us to a difficult truth. When an algorithm says yes to one patient, it is, by necessity, saying no or wait to another. That's not just a technical function. That's policy, quietly, invisibly rationing care. Rationing has always existed in healthcare, dictated by budgets, bed space, and available specialists. But algorithmic rationing is different. It's automated, it operates at an unprecedented scale, and its rules are often hidden inside a proprietary black box, shielded from public view. So who's really in charge of writing these new rules for life and death? The shadow policy. Sometimes policy is set not by debate, but by default. Imagine this. An AI model denies a patient's care. The hospital, trusting the algorithm, follows the recommendation without review. No one questions the output. In practice, the algorithm's decision quietly becomes policy, unseen, unchallenged, and unaccountable. This is how policy by default happens, shaping real lives without a single vote or discussion. But what are the consequences? When no one questions the algorithm, errors and biases can go unchecked, leading to real harm. True leadership means not just accepting the status quo, but actively reviewing and challenging automated decisions to protect patient welfare and uphold ethical standards. Is it the doctors who are increasingly prompted, guided, and second-guessed by these systems? Are they empowered by a new tool? Or are they slowly ceding their autonomy to a machine whose reasoning they can't fully inspect? Is it the hospital board, which purchases these systems with mandates to improve efficiency and reduce costs? Are their financial incentives aligned with the best possible patient outcomes, or just the most profitable ones? Is it the tech companies writing the code? These brilliant engineers are focused on optimizing for mathematical precision, but they may not be trained in clinical ethics or health equity. They can build a powerful engine, but should they be the ones deciding its destination? Or is it the policymakers who are struggling to create regulations for a technology that evolves faster than the law can keep up? How do you regulate an algorithm that is constantly learning and changing? How do you ensure accountability when a decision is made by a distributed network of software and hardware? This complex web of questions leads us to a crucial issue. Who actually sets the policies when algorithms start rationing care? Solving this challenge requires input from many perspectives. It's not just about building smarter technology, it's about deciding who gets to shape the rules that guide these systems. Doctors, hospital boards, technology companies, and policymakers all play a part. Each brings a different set of priorities and values to the table. The real question is, who should have the final say when algorithms make decisions that affect lives? We need open conversations about fairness, transparency, and accountability. The answer can't come from a single group or behind closed doors. It must include everyone, especially those most affected by these decisions. Let's be clear, the potential here is revolutionary. Algorithms can spot patterns in a genomic sequence or an MRI scan that the human eye would miss. They can optimize hospital workflows to reduce wait times and prevent errors. They can help us move faster, be more efficient, and they will absolutely save lives. But they are a mirror, reflecting the biases and blind spots of the data we feed them and the priorities of the people who design them. This is why we need leaders trained in systems thinking, because it's not just about what AI can do, it's about who decides how it's used. If the data is skewed, the decisions will be too. The machine doesn't have a conscience. It can't question its own assumptions. That's our job. So what do? We don't unplug the machines. We get smarter about how we build and use them. We need leaders who understand both the science and the social context, people who can bridge the gap between medicine, technology, and policy. We need to demand transparency and the right to audit these algorithms. We need to insist that clinicians are trained to work with AI as a partner, not a commander, and are empowered to override it. We need to build systems that are not just accurate, but equitable. We need people who ask the hard questions, like, are we okay letting a machine decide who gets the last ICU bed, or who moves to the top of the transplant list? or who is deemed worthy of a second chance. Because at the end of the day, healthcare isn't just about data points and efficiency metrics. It's not just about treating bodies. It's about our fundamental values. It's about dignity, compassion, and justice. It's about who we as a society choose to care for and how we express that care. The algorithm will see you now, but who decides what counts as care? The answer can't be left to the machine. Maybe, just maybe, it has to be all of us. Let's break down who actually sets policy when algorithms ration care. Policymakers, like legislators and regulators, write the laws and set the rules. Health systems executives make decisions about how care is delivered. Insurance companies decide what gets covered and how. Tech vendors design and maintain the algorithms themselves. And public health leaders help guide priorities for entire communities. Each group shapes the system in different ways, and together they decide how care is rationed in the age of algorithms. Let's dive deeper into a real-world scenario. Imagine an AI system in a busy urban hospital, prioritizing patients based on data. A young man with chest pain is flagged as low risk due to his age, but the AI misses a rare heart condition. Meanwhile, an elderly patient is prioritized for a minor issue. These decisions made in seconds can have life-altering consequences. The challenge is ensuring the algorithm's logic aligns with clinical reality and human values. Let's break down how bias can become a self-reinforcing cycle in AI-driven healthcare. Imagine using a cracked compass to map a nation's future. If the data we feed into AI is already biased, reflecting past inequities, the AI will learn those patterns. Then, when policies are set based on the AI's recommendations, those same biases get locked in, shaping real-world outcomes and deepening the divides. The feedback loop is complete. Biased data leads to biased AI, which leads to policy that cements inequity. To break the cycle, we must fix the compass by questioning our data, our assumptions, and the systems we build. Here's a surprise. Many rationing decisions are already quietly happening in U.S. healthcare through insurance denials and coverage tiers. AI just makes these decisions faster and often less transparent. Hope and solutions are emerging. Community-led data initiatives ensure everyone is visible in the system. Algorithmic auditing helps flag and fix bias before it harms. When AI is paired with equity-first policy, it becomes a bridge, not a barrier, to better care. The fight for inclusive AI is the fight for inclusive health systems. Let's look through an equity lens. When algorithms ration care, the impact isn't felt equally. Rural communities may face longer waits or fewer resources. Black maternal health outcomes can worsen if the data ignores lived realities. Undocumented families may be left out entirely, unseen by the system. Leadership means not only setting policy, but questioning who the policy was built to serve. True progress demands we ask, who benefits and who is left behind? Algorithmic rationing isn't new in spirit. It echoes a long history of systemic exclusion. Decades ago, redlining kept entire communities from opportunity. Black Americans and other minorities were excluded from clinical trials, their health needs ignored. The Tuskegee study stands as a chilling reminder of how systems can harm when they decide who counts. Today's algorithms risk repeating these injustices, only faster and hidden behind code. If we don't learn from history, we risk building tomorrow's harm on yesterday's wounds. Behavioral science shows us that people often distrust systems they can't see or understand. Ethics asks, who decides what's fair? True leadership means seeing the whole system and questioning it. When algorithms ration care, the hidden costs ripple outward. Emergency rooms become overcrowded as patients delay care. Chronic conditions go untreated, leading to more severe illness. Communities lose trust in the system, and inequities deepen. The downstream effects are real, and they're growing. According to the U.S. Health Resources and Services Administration, as of 2023, more than 150 million Americans live in areas with a shortage of mental health professionals. Recent studies also show that AI tools in healthcare can perpetuate or even amplify existing biases, impacting care for vulnerable groups. If you were the health commissioner, would you use an algorithm that saves more lives overall, but leaves rural mothers behind? What leadership lens do you apply? Close your eyes. Imagine two patients, one urban, insured, with a smartphone full of health data, the other rural, uninsured, no digital footprint. Which one does the AI prioritize? Who made that rule? Would you trust an algorithm to decide if your loved one gets care first? Why or why not? If this sounds like an episode of Black Mirror or the world of Gattaca, that's because we're living it. The future is here, and it's making decisions about our health. In the UK, the National Health Service uses AI to support universal access. We're aiming to allocate resources fairly across the population. Decisions are guided by national policy and public values, with transparency and equity as core goals. In contrast, the US system is more fragmented, with AI often used by private insurers and hospitals to manage costs and prioritize care. This can lead to greater variability and less transparency, as decisions may be driven by financial incentives as much as patient need. Both systems face challenges, but their approaches to AI rationing reflect deeper differences in how each society defines fairness in healthcare. Thank you for watching Tomorrow's Consciousness. This episode, Who Sets Policy When Algorithms Start Rationing Care, was about more than algorithms. It was about leadership, systems, and the choices that shape who gets care and who doesn't. I'm Rukia, and my vision is to help build public health systems where no community is invisible and no policy is written without equity at its core. That's the work of systems leadership, connecting data, technology, and humanity into a future that serves everyone. So as we close, remember, algorithms don't set policy, people do. And the leaders we train today will decide the health of tomorrow. The algorithm will see you now. Let's follow the money. Every decision made by an algorithm in healthcare is influenced by financial incentives. Insurers, hospitals, and tech companies all have a stake in how care is rationed. By tracing the flow of money, we can uncover who truly profits when algorithms decide who gets care and who is left behind. Behind every algorithm that rations care is a web of financial incentives, some obvious, some hidden. Insurers may save millions by denying or delaying treatments, while patients face real health consequences. Hospitals may tout efficiency, but at what cost to patient outcomes? Some incentives are clear, like cost savings for insurers and hospitals. These are often reported in financial statements and used to justify the adoption of AI systems. Other incentives are hidden, embedded in the code and decision-making processes of algorithms. These can include subtle biases that prioritize profit over patient care or policies that exclude vulnerable populations. When an AI system flags a patient for denial or delay, who benefits? Often, it's the insurer or hospital that saves money, while the patient bears the risk of worse health outcomes. And at what cost to the people who need care most? Delays and denials can lead to serious complications, increased suffering, and even loss of life. Start with the insurers. For them, algorithms are a powerful tool to cut costs and maximize profits. Automated claim reviews and denials can save billions, but may also deny necessary care to patients. For hospitals, algorithms help manage limited resources, but can also shift decision-making away from clinicians and toward financial goals. By automating claim reviews, insurers can process thousands of cases quickly, but this speed can come at the expense of careful, individualized review. Flagging cases for denial is often based on patterns in data, not the unique needs of each patient. This can lead to unfair outcomes, especially for those with complex or chronic conditions. These systems can save billions, boosting quarterly earnings and satisfying shareholders, but the human cost is often invisible in financial reports. In 2022, major U.S. insurers reported record profits, citing efficiency gains. But these gains often come from denying or delaying care, not from improving patient outcomes. But there's a catch. Every dollar saved by denying or delaying care is a dollar not spent on someone's treatment. The savings for insurers can mean real losses for patients. For patients like Sarah, that efficiency can mean longer waits, more hurdles, or outright denial of life-saving interventions. More hurdles can mean more paperwork, more appeals, and more stress for patients and families, or outright denial of life-saving interventions, which can have devastating consequences. Hospitals also walk a financial tightrope, balancing the need to provide care with the pressure to cut costs. Many adopt AI to maximize limited resources, freeing up beds, reducing readmissions, and hitting key performance metrics tied to reimbursement. Reducing readmissions is a key goal, but algorithms may prioritize this over patient needs. And hitting key performance metrics tied to reimbursement can sometimes overshadow the goal of providing the best possible care. But the pressure to cut costs can push care decisions out of the hands of clinicians and into the logic of a machine optimized for throughput, not compassion. Doctors and nurses may find themselves second-guessing their own judgment or unable to override algorithmic decisions that don't fit the patient's needs. Let's dig deeper. Who writes the code? Tech vendors sell algorithms as cost-saving solutions, promising health systems a competitive edge. The more efficient the algorithm, the more marketable it is to hospitals and insurers. But efficiency for whom? Tech vendors may not always consider the ethical implications of their algorithms, focusing instead on performance and profitability. Promising health systems a competitive edge can lead to a race to the bottom, where cost savings trump patient care. The more efficient the algorithm, the more marketable. But efficiency for whom? Patients or the bottom line? But efficiency for whom? The answer is often those who control the purse strings, not those who need care. Thanks. And what happens when the quest for savings quietly shapes how care is rationed? Vulnerable groups may be disproportionately affected. Compare the outcomes. Studies show cost-driven algorithms can harm patient outcomes, especially for those with complex or chronic conditions. A 2021 review found AI-driven denials disproportionately affected patients with complex or chronic conditions, leading to delays in care and higher rates of emergency room visits. Delays in care can lead to worse health outcomes, more suffering, and higher costs in the long run. And higher rates of emergency room visits can overwhelm hospitals and increase costs for everyone. Now step back. Who's really setting policy? When financial incentives are built into the system, leadership means more than just following the numbers. It means asking who profits and who pays the price. True systems leadership demands transparency and accountability at every level. It means tracking the flow of money from algorithmic decisions all the way to patient outcomes and holding every stakeholder accountable, not just for the bottom line, but for the lives behind the data. Because when we follow the money, we see the real power dynamics of healthcare. Only by demanding transparency can we ensure that algorithms serve people, not just profits. True systems leadership demands transparency. It means pulling back the curtain on financial incentives and making sure that patient care comes first. Tracking the flow of money from algorithmic decisions to patient outcomes is essential for accountability and equity. Holding every stakeholder accountable, not just for the bottom line, but for the lives behind the data, is the hallmark of true leadership. Because when we follow the money, we see the real power dynamics in healthcare. Only by demanding transparency can we ensure that algorithms serve people, not just profits. And if we want a future where algorithms serve everyone equitably, we need leaders who are willing to pull back the curtain, challenge the incentives, and put people, not profits, at the center of policy. Challenge the incentives, ask hard questions, demand accountability from every stakeholder in the system, and put people, not profits, at the center of policy. That's the only way to build a healthcare system that truly serves everyone. As we reflect on the questions raised today, one truth stands out. The future of healthcare isn't just coded in algorithms. It's written in the values of the people who build, regulate, and use them. Leadership is more than a title. It's the courage to challenge the status quo, to ask uncomfortable questions, and to build systems that see every person, not just every data point. Imagine a round table, not in a tech lab or a hospital boardroom, but in a community center. Around it sit doctors, nurses, engineers, patients, policymakers, and advocates. Each voice is valued. Each story matters. Together, they examine how an AI system made a decision, who it helped, who it overlooked, and why. They asked, how might this algorithm look if it were designed by those it most affects? What safeguards can we put in place to ensure no one is invisible? This is the future of leadership in AI-driven healthcare, not just technical expertise, humility, collaboration. Leaders who demand transparency, who listen to frontline clinicians, who listen to patients, who push for regular audits, and who seek community input. Leaders who see technology as a tool for justice, not just efficiency. As we close, remember, every line of code reflects a choice. Every policy shapes a life. The path forward is clear. We must train leaders who bridge disciplines, who understand data, who understand medicine, who understand the lived realities of diverse communities. We must insist on equity as a foundation, not an afterthought. Thank you for joining us on Tomorrow's Consciousness. Together, we can shape a future where AI in healthcare serves everyone, fairly, compassionately, transparent. Because in the end, the algorithm may see you now, but it's people like you who decide what care truly needs. Expanding leadership means including voices from every community. Policymakers, clinicians, patients, and technologists must collaborate to audit algorithms and set transparent standards. Community advisory boards can help ensure that AI systems reflect the needs and values of those they serve, not just the priorities of institutions.